Hello, I am Mirella Cameran-Reilly, and I'm delighted to welcome you today to the Hamptons Health Hotline. The Hamptons Health Hotline is brought to you by the Southampton Hospital Foundation. The hotline is a way for you to get to know the doctors who are working in your community. We're going to be asking them about the most important healthcare issues of the day: heart disease, stroke, diabetes, cancer, tick-borne diseases, and more. We want to learn from them what is the latest thinking on these conditions and the best therapies and ways to reduce risk. The hotline, though, is also a way for you to connect with us. We want to know what you're worried about, what keeps you up at night. So please send us your medical questions to our Facebook, Instagram and Twitter handles. It's all the same, Southampton Hospital Foundation. So please send those in. We will do our best to answer all of them in future episodes. Today's episode starts with a question. What do Halle Berry, Larry King, Tom Hanks and Nick Jonas have in common? Well, the answer may surprise you, and it's diabetes. And today's issue is to talk about diabetes, to understand more about it, to learn if there are ways we can avoid it, and what to do if you're living with the condition. I'm really happy to have with me today Dr. Travis Bench. He is an interventional cardiologist at Stony Brook Southampton Hospital. And before we get stuck into the meat of this discussion, I just want to introduce him and ask him to tell you, our viewers, a little bit more about him and how he came to be working at Stony Brook Southampton. So Travis, thank you for coming today.
Thank you for having me. So, I'm Travis Bench, and I'm an interventional cardiologist at Stony Brook Southampton. I graduated medical school from Stony Brook in 2006 after I had a career as a physician assistant. After studying cardiology and interventional cardiology, I was briefly in private practice, but came out to Southampton in 2016, where we put together a cardiac catheterization program, and where I'm the co-director of the lab and the director of the CCU at the hospital. So I've been practicing medicine now for about 7 years, and I live on Long Island since 1994.
Wow, so you know the area, you know our communities really well.
Absolutely.
Great. So all the names I mentioned, Randy Jackson, Halle Berry, Larry King, Tom Hanks, Nick Jonas, apparently they all suffer from type 2 diabetes. And according to the American Diabetes Association and the Center for Disease Control, over 30 million Americans, that's 10% of the population, suffer from some form of diabetes. It is the 7th leading cause of death in the US, and people believe that's probably underreported. So there's probably more people living with that condition than we know about, and maybe they know about too. So diabetes is not one thing. Could you just explain to us, what this group of diseases is?
Sure. So we're talking about diabetes mellitus. So diabetes itself it comes from a Greek word that means siphon. So back in the day, they noticed that there were some people that actually produced very large amounts of urine. And when they studied these people, obviously there was a number of diseases that they were found to have. So diabetes insipidus is actually a disease that deals with a hormone in the brain called vasopressin or antidiuretic hormone. But the diabetes that we're talking about is diabetes mellitus. It actually is a disorder of the blood sugar. And specifically type 1 diabetics do not produce enough insulin. And so insulin is the hormone that our body uses to transport the blood sugar in our blood into the cells of our body to be utilized. So again, type 1 diabetics do not produce enough of this hormone to do the job that they need to do. Type 2 diabetics are a little bit different. These are people that actually develop a normal pancreas. They secrete normal amounts of insulin, but that insulin is not effective primarily because their body tissue is resistant to the effects of the insulin. And then there's a third kind of diabetes that we should talk about called gestational diabetes. It's a condition that is high blood sugars during a woman's pregnancy. The manifestations of that disease are a little bit different. A lot of times they'll be diagnosed with gestational diabetes and it will go away after the birth of their child. But down the road, these women have an increased risk of developing type 2 diabetes. So yeah, there is a wide spectrum of disease, and it's not all the same etiology.
Are you predetermined to get either one of those types of diabetes?
I mean, it's a great question. the genetics or the inheritable predisposition to develop diabetes has not been worked out. Type 1 diabetics, it's hypothesized that this may be a genetic predisposition or something inheritable, or it may be an autoimmune disease where their body sort of attacks the pancreas and destroys the cells that secrete the insulin. We believe, based upon the fact that there's a higher incidence of type 2 diabetes amongst some races, that there may also be a genetic predisposition, but the genetics of that have not been worked out.
Is there anything that we can do to stop getting diabetes? I mean, what is that situation? How much are we in control of the disease in that way?
So it's interesting because, 100 years ago, obviously there were still diabetics around and we were dealing with the same problems. But if you look at the modern prevalence of diabetes, it correlates very, very tightly with the obesity epidemic.
Okay.
And so, as it turns out, adipose tissue, the fat cells in our bodies are very resistant to the effects of insulin. And so you can't have an honest conversation about diabetes without also addressing the obesity epidemic. And although it's very difficult to lose weight and to keep it off, at least there is something that we can do about it. Regarding your question specifically, how do we reduce our risk? How do we control this disease, long term? And a lot of it has to deal with weight management.
Mm-hmm. And how does someone know if they have diabetes? I mean, is it always obvious? Does it result in a heart attack and then they realize that the diabetes caused something? How do we know?
Very unfortunately, as a cardiologist, obviously I see a lot of people that have developed the cardiovascular diseases associated with diabetes. So exactly, the heart attack and stroke. And in the worst case scenario, a lot of times people come into medical care for the first time after having suffered from a stroke, a heart attack, in heart failure, whatnot. Just like high blood pressure, which is nicknamed the silent killer, diabetes can be undiagnosed for years and years and years because the symptoms can be very subtle. Going back to what I said, when I opened up, the term diabetes comes from this Greek word for siphon and from urine production. So people may have, an excessive amount of urination. They may be thirsty all the time and dehydrated. Other signs and symptoms, they could have blurry vision. They could get frequent yeast infections. But all of those things could just be ignored as the symptoms of almost any other illness. And so if you don't experience something that sort of brings you to the physician, you're not going to be diagnosed at an early point in that illness. And again, that's very similar to what we see with hypertension that goes on for years without causing symptoms until finally people get diagnosed when there's already, end-stage organ damage. So it is a challenge.
So could we just go out and buy a simple blood test kit?
You could. However, the interpretation of any test requires some understanding of it. The diagnosis of diabetes is made several different ways. One way is a fasting blood sugar, right? So yes, you could go buy a over-the-counter blood glucose kit and look up on Wikipedia what your blood sugars could be, and after an 8 to 12 hour fast, check your blood sugar and sort of come up with an idea. But there are other ways to diagnose diabetes. It may be indicated based upon the results of a normal urinalysis. There's also other tests that have strict diagnostic criteria, such as a glucose tolerance test, which a lot of women have during pregnancy, where they're given an oral glucose load and then their body's response to that bolus of glucose is monitored. And also there is a blood test called a hemoglobin A1C, which gives us an idea of what the average blood sugar has been over the last 2 to 3 months. So you shouldn't really go buy your own home test strip. You should follow up with your primary doctor such that even small abnormalities in your fasting blood sugar can be evaluated further with any number of other tests.
And is that something that your primary care physician would normally test for?
Absolutely.
Okay.
Absolutely. I mean, again, based upon signs and symptoms, routine blood work is done almost at any routine visit on an annual basis, and certainly can be done sooner if necessary based upon the development of any of the symptoms I talked about previously.
Okay. So, prediabetes, what is that?
So, prediabetes is a definition that was invented in order for us to start addressing risk factors early in the stage of illness.
Okay.
So classically, diabetes would be a fasting blood sugar over 126 milligrams per deciliter, strictly by the books. However, we now know that if we wait for somebody to develop full-blown diabetes, a lot of times, medically speaking, we're behind the eight ball. They've already developed, I'll say, end organ damage, problems with the eyes or the kidneys or whatnot, whereas if we were treating them from an earlier stage in the illness, we could have avoided. So prediabetes is really a condition where we recognize that somebody's response to glucose is not normal. And it's at that stage that if we intervene, we may be more successful in delaying or preventing the cardiovascular complications that we see, the blindness, the kidney disease, the nerve problems in the legs. And it's just a lower diagnostic level. May not require the same intensity in medication therapy, but certainly a point where we need to act as physicians.
And so talk us through again the problems that diabetes typically causes if it is, allowed to increase.
Again, just medically speaking, I mean, that lab test, the hemoglobin A1C, is a fairly common test, and most diabetics are aware of it from the initial diagnosis. What's interesting is that the hemoglobin A1C addresses your blood sugar levels specifically. And we know that the hemoglobin A1C number is very, very tightly correlated with the development of retinopathy, which are problems with the eyes, nephropathy, problems with the kidneys, and neuropathy, problems with the nerves in our legs. Unfortunately, we also found over the course of time that the A1C, so then the blood sugar level itself, does not alter the cardiovascular complications. So diabetics, regardless of their blood sugar control, have a fourfold increased risk of cardiovascular disease, meaning heart attack and stroke. And blood sugar control has not been found to alter that risk. And so although with diabetics, we know it's a disease of blood sugar, and we know that it involves the hormone insulin, there's a lot of metabolic factors, other hormones that are involved with the illness. And actually, very, very recently, there have been new meds put on the market that target some of these other hormones and have been shown to alter the cardiovascular risk. So as a cardiologist, the patients that I see, I'm most concerned about the possibility that they could be putting themselves at risk for a heart attack or a stroke.
So just so we understand this, even so having diabetes increases your risk of cardiovascular disease and those complications such as heart attack, heart failure, but the blood sugar level control doesn't help mitigate those factors?
Correct. Blood sugar control is imperative to the disease. If your blood sugar is not controlled, that can be fatal, right? I mean, we talk about type 1 diabetics, and they're at risk for something called ketoacidosis, and that can be a fatal condition. However, keeping your A1C at 6, let's say, at a normal level for diabetics, that would be a great level for diabetics, to be honest with you, does not alter their cardiovascular risk. And it's such that in cardiovascular medicine, when we have a diabetic that comes to us for treatment, we talk to people about blood pressure control, and we talk to people about their cholesterol levels. The diagnosis of diabetes is what we consider to be a coronary artery disease equivalent, meaning that when you come in with a diagnosis of diabetes, in my mind, I see somebody who has cardiovascular disease, and it affects how aggressive I treat their blood pressure and how aggressive I treat their cholesterol levels. Because when you're talking to somebody about prevention, it makes sense to work with people. Borderline hypertension, you hear people talk about, or have borderline high cholesterol. But when you're a diabetic, and I know your risk of a heart attack and stroke is so high, allowing somebody to be borderline anything just doesn't make sense. So the American Heart Association has set much lower goals for blood pressure control and cholesterol control in diabetics because their risk of cardiovascular illness is high, regardless of their glycemic control.
And what things can you do to control those factors that cause the cardiovascular disease?
Well,
is it medication? Is it lifestyle?
So any good doctor is going to tell you that the more people are able to do on their own, right, the less dependent upon the medications we become. I don't like pushing medications. I mean, that comes up very frequently as well. And I always encourage, obviously, people to do, regular exercise, maintain a healthy lifestyle, low sodium diets, low saturated fat diets. We can talk more about that. But unfortunately, the data that exists takes into account the effects of certain medications. I mean, for one, given the cardiovascular risk of diabetics, every diabetic should be on an aspirin a day. And that's regardless of the recent trials that have been published in the paper about aspirin. If you read through those trials, diabetics and people that were of high cardiovascular risk were excluded. Additionally, we have a lower set point, like I said, for cholesterol control. So again, if you have a diagnosis of diabetes, having a normal cholesterol, although it may be normal for somebody without diabetes, is not appropriate for a diabetic, and their goals should be lower. So quite frequently, the diagnosis of diabetes means you're on an aspirin, and quite frequently you're on a statin as well.
Okay. I think I heard someone say once that having diabetes puts you at the same risk as someone who's already had a heart attack. Is that right?
I don't know that it is as high, but yes,
You're in that kind of ballpark of risk,
absolutely.
just to kind of quantify it for people. Okay, so when it comes to healthy lifestyle and diet, we know so much about it. We hear so much about all the things we should be doing. Some of it's really confusing. Some of it's about, celery juice. Some of it's about plant-based diets, paleo diets. It's harder than it seems to know what to do and then obviously to follow through.
Absolutely.
So how do you encourage your patients? What do you say to people?
So first of all, it's also important to understand that it's even higher in diabetics. So insulin is a growth hormone. The job of insulin is to take what you ate and store it as fat. That's what insulin does. So when a diabetic that has a high level of insulin floating around their body because their body is resistant to the effects, and they may be on exogenous or they have to take insulin shots as well to control their blood sugar, that much insulin floating around their bodies is telling them to take even a little bit amount of food that they ate and store it as fat. So for diabetics, it's even harder to lose the weight, right? Obviously, all of the same sort of dogma applies. A diet low in saturated fat. When it comes to exercise, it's really as simple as calories in and calories out. There has to be some degree of aerobic exercise to sort of burn off or metabolize that extra glucose, bring down that insulin level. But what's really, really fascinating is that in 2012, the New England Journal of Medicine published a paper that evaluated what we had been doing for years and years and years, medical management of diabetes, and they compared it to gastric bypass surgery. And what they found is that cardiovascular risks, glycemic control, everything improved in people that had gastric bypass surgery. And weight loss became sort of the cure for diabetes. It's not something that is easy to do. Myself, many people that I know struggle with it every day. But it really has to be sort of a diet that's low in saturated fats. We have to avoid those, especially if you're diabetic, you have to avoid those processed carbohydrates and sugars. I know we all love them, but the soda, the soft drinks that are out there. I mean, it seems that sort of highly processed sugars have just sort of taken over our lives in terms of how we eat. Some of it is probably lifestyle. Many of us don't have the time to go home and prepare the meals that we want to, and we eat on the run. There may be, two working parents in a family, and they pick up something on the way home. And I think this all contributes to it. And it's not an easy fix. But again, as a physician, I think it's important that I sort of, empathize with the fact that when somebody has diabetes, telling them to go lose weight is sometimes an impossibility because their insulin requirements and their level of circulating insulin is so high that it's really not realistic to tell them to do these things. They could eat whatever they want, their body's going to store it as fat, and sometimes it leads to a referral for bariatric surgery.
So bariatric surgery is something obviously that is offered at, is available at Stony Brook Southampton.
Bariatric surgery itself, I do not believe is available at Stony Brook Southampton. We do refer up to Stony Brook. There are a number of institutions. I mean, this is only over the past 8 years that sort of the research on this, has really taken off in terms of how we manage diabetics, pre-diabetics, people with existing cardiovascular disease. Prior to this, a lot of people looked at it as purely a cosmetic procedure. But the research on it is, undeniable at this point in time that treating obesity with weight loss helps us in terms of diabetic control, hypertension, and long-term risk of cardiovascular disease.
And I know that at Stony Brook Southampton that there's a great wellness program.
Absolutely.
With some amazing clinical nutrition, information.
And that's imperative too,
Yeah.
right? I mean, sort of going through somebody's diet and helping them recognize foods that they like to eat. I mean, you know, eating is also a very social thing, right? And we all enjoy doing it and hanging out with our family, and you can't remove that from somebody's life. I mean, the goal here is to make somebody healthier, but you also want people to be happy. So having a good nutritionist that can sit down and go through your daily regimen and sort of help pick out the things that you're doing that are right and the things that are doing that are not so great, getting you involved with, you know, exercise therapists. And a lot of these patients, again, have cardiovascular disease. We have an amazing, you know, cardiac rehab program at Southampton Hospital, and, you know, they can help sort of restore some function and get somebody on the right track. So again, it has to be a holistic approach. Medically speaking, yes, it involves medications, but again, the more that we're able to do non-pharmacologically, the less dependent upon these meds we become.
And we are going to be having Paula, who I think is the Director of Clinical Nutrition at Stony Brook Southampton, in the kitchens here at LTV, showing us some healthy ways to enjoy all the amazing, you know, fruits and vegetables that are available out here, and particularly in the summer months, and how to enjoy them in a healthier way than maybe we do normally. Now, what about the other stuff like alcohol, smoking, those kind of? We haven't touched on those, but they must have a bearing on this.
So again, like we talked about with the high blood pressure and the high cholesterol, right? It's if you have multiple risk factors for cardiovascular disease as a cardiologist, you know, addressing one of them is not appropriate. They all have to be addressed. I don't know anybody who looks me in the eye and tells me why they can continue to smoke cigarettes. I mean, the data on cigarette and tobacco use is out there. Unfortunately, we haven't had the same data on vaping, which is now a new thing. We don't know what the long-term sort of consequences of this will be. We've certainly seen people develop pulmonary complications, but again, from a cardiovascular risk standpoint, I can't support it, but I don't have the data to tell anybody about it. You mentioned, in addition to the cigarette smoking, you mentioned alcohol. It's kind of in the same light. We know that alcohol does have negative effects on the heart. If you're talking about it purely in the context of what it does for diabetes and other sort of conventional risk factors, most alcohols have a very, very high sugar content. We know that a lot of them also have a very high sodium content, so it will affect your diabetic control, it'll affect your blood pressure control, aside from the negative cardiac effects of it. There is data to support red wine, right? So again, some of this data seems conflicting, and why that is, we don't know. It certainly seems that, you know, moderate alcohol intake, sort of 1 to 2 glasses of red wine a day, appears to be healthy. But again, if you're a diabetic, that's not the population of people that were really studied when we talk about this. So again, everything has to be taken in context of what it does to your blood sugar and how many calories it adds to your daily caloric intake.
So I know every cardiologist I meet, I always say, how much red wine can I drink? And obviously, what you're saying though, it's very specific to you and your risk factors, and getting the right team to help you is really important. You know, the nutritionist, your cardiologist, making sure that someone can kind of treat you as a whole person and help you.
And you need somebody that actually looks at you and not, you know, the broad generalization of what we should be doing. Again, I touched upon a research paper. There was a couple of them that were published about 2 years ago that commented on, you know, the use of aspirin. And then there was another paper around the same time that commented on the use of statins in older patients. And, you know, it created a lot of angst for people. They had a lot of questions about the regimen, and they wanted to know why they were on it if these studies, you know, clearly said there wasn't an advantage. But the patients that came to me weren't seeing themselves as a patient, right? They saw themselves as everybody else. And same thing, we have to look at diabetics, we have to look at people who've had a heart attack or have had a stroke. We have to look at them as a special population of people that have already shown us that they have a risk, and we need to be aggressive with their risks. And unfortunately, these are the medications that we use that have been very, very well documented to lower that risk.
We haven't got much time, but we did touch on gestational diabetes in women. You said that oftentimes can go away afterwards, but your OBGYN would check for that.
It's always tested during pregnancy, so they're going to be monitoring you during your pregnancy for gestational diabetes. If you are diagnosed with gestational diabetes, again, it may go away after your pregnancy. However, we know that women with gestational diabetes have a higher risk of developing type 2 diabetes later in their life. Okay. Specifically regarding its effects on pregnancy, what's interesting is that it causes women to have babies that are larger than they should be for their gestational age. So a lot of times women will go into preterm labor because the child is so big. Because of the size of the child, a lot of times women will have to have a cesarean section. And if they don't, it could be a problem with sort of injuries from the birth of a large baby. After the birth, there are specific challenges for the baby as well, because the high circulating levels of insulin from the mother will oftentimes drop the baby's blood sugar very, very low. So a lot of times these babies, neonatals, babies will need a short period of time in the ICU to monitor their blood sugar. So yeah, it is a different disease, and sort of, again, not completely understood whether there's a hereditary disposition to a certain amount of glucose intolerance in the woman itself that just sort of manifests in pregnancy, and then later in life, we don't know.
Would the baby necessarily be more predisposed to diabetes, or?
It's interesting. I don't know the statistics on that.
Yeah. Well, we are out of time, but thank you ever so much. It's always good to hear from the horse's mouth and try and understand more about what we can do, what we're at risk of, and to help those people around us too in our families. Absolutely. To understand how to get them the best care for them as individuals. Thank you ever so much.
Thank you.